recording button. There we go. We'll give a couple minutes for people to join in. We'll go for an hour. I have to leave personally at right around 6, but I will hand over the hosting of this to Steve or someone else, so we can, if the conversation wants to continue, that's not a problem.
We'll see if we can find a volunteer who's less likely to kill the whole thing than.
And I imagine we probably can. And all I can say is it's great to see all of you. And I actually think I recognize still almost all of you, which is always a good sign, at least for me. Steve Scheinman has been gracious enough to agree to talk with us about healthcare. I love the title, Where Are All the Doctors Gone? And it's something we all need to worry about more and more, I think, as we gain in seniority. I guess that's a nice way to put that. I'm going to remember that. Anyway, couple minutes, it's 2 after, we picked up a bunch of people. Nobody is muted specifically on this, so you can all talk all at once. But as we all know from our Zoom experience, that if you're talking, somebody else isn't talking or can't talk. So try to be polite. If it's possible that you have comments, there is a chat function for this, obviously, that people are familiar with. You can certainly put questions for Steve in the chat, and either he or I or someone will monitor the chat as we go along and make sure that the questions get addressed as we go. Given the fact that we're gaining folks right now, rather than wait, Steve, why don't we just let you have at it, and welcome.
Okay, well, thanks, Bob. And I agree with you. I like the title, although it does imply that the doctors have gone somewhere. I think a certain number of them have gone onto the screen here. It looks like probably over half the people on the screen are people who could also offer a valuable perspective on this question. But I'm happy to start with some reflections from my perspective. I've served, as Bob was saying a minute ago, as the dean of 2 medical schools, upstate in Syracuse and Geisinger in Pennsylvania, for a total of 18 years before I retired 3 years ago. I was president at one of them. I've chaired the board of the National Resident Matching Program, and I've served on panels advising the governor on physician workforce in both New York and in Pennsylvania. And I'm really glad that we have some other people on the screen who are very knowledgeable here, because I'll be looking forward to their perspective as well. So I'm going to start out by acknowledging, because after all, America is great, that we do have, at its best, the very best technology of care for illness in the world. There are other places, I don't know who's got the background. Somebody's family is talking. Could you mute yourself? Thanks. At its best, our technology is unsurpassed. It's not that there aren't other places in the world where you could go to find the very finest technology as good as ours. But the best healthcare isn't available to everyone, and our health outcomes are far from the best. There are huge disparities in cost, in access, and quality, contributing to huge disparities in outcomes. So just to start with a few statistics, something we all know. The US spends more per capita on healthcare than any other country. It's 17.5% of GDP. Number 2 is Switzerland, which spends 9%, just under 9% of its GDP on healthcare. So that adds up to $13,500 per person, which includes $1,000 per person for the entire population of the United States paying for healthcare administration. That's 5 times the average of other developed countries in the OECD. And that is, in the aggregate, more than we spend on long-term. We spend more on healthcare administration than on long-term care, which is a very frightening thought for those of us who are approaching long-term care age. And despite all these expenditures, we have the worst health outcomes of all the countries in the OECD. For example, in the world, We rank number 48 for life expectancy. We rank exactly between Panama and Estonia. We are behind all of Western Europe. And just for reference, number 1, longest life expectancy in the world is Hong Kong. Number 2 is Japan. Number 3 is South Korea. I'll come back and use other comparators with Japan and South Korea. Our maternal mortality is higher than any other developed country. 21 women out of 100,000 live births die. For comparison, in Switzerland, it's 7. In Japan, it's 4. Ours is 21. Infant mortality is similar. We have 5.1 deaths per 1,000 live births. So that's nowhere near as high as most of Africa, but it ranks us somewhere between Romania and Slovakia. And for comparison, we are 5.1, Switzerland is 3, Japan is 1.9 per 1,000 live births. Preventable mortality in the United States is 336 deaths per 100,000. In Switzerland, it's 130. In Japan, it's 137. Preventable mortality encompasses deaths of all sorts that often have nothing to do with health care. And our COVID outcomes, hospitalizations, deaths, COVID outcomes per capita were much worse in the United States than in other developed countries. And then if you take these aggregate numbers for the country as a whole, among Americans, there are huge disparities within America in outcomes. So within cities, for example, there's a 20 to 30-year difference in life expectancy in the same city between zip codes. And of course, the irony here is that the highest out-of-pocket costs are paid by those with the lowest income. The uninsured are the only ones who pay retail list price for healthcare. So why are these outcomes so bad? Well, part of it is access to doctors, which is the topic for today, but more importantly, there are other factors that explain this, because it's been estimated that access to healthcare, quality of healthcare, account for only about 20% of all healthcare outcomes. There are other factors, some of which we can do nothing about, genetics, for example, and others which we can do a lot about but haven't, such as the dangers in the environment, socioeconomics. I've just mentioned zip codes. In the aggregate, these things, these social determinants, account for more of the health outcomes than access or lack of access to health care. And the U.S. lags in this respect. We have greater socioeconomic inequalities. We have much higher rates of obesity than in other developed countries. Deaths from overdoses and gun violence in the United States, those numbers are far ahead of other countries. And there are a variety of other factors unrelated to healthcare. The U.S. is also the only developed country that does not guarantee health coverage to everyone. And if I hadn't said that, Dick Tonino would not speak to me again. But it's the truth. So access to care is a serious problem for the uninsured, for the poor, for those who live in rural areas, and for in inner cities, both because of affordability and availability. But it's even a problem for us in the 1%, getting an appointment with a doctor in a variety of specialties, but certainly in primary care is something that we've all experienced. So compared with other developed countries, patients in the United States are more likely to report that they don't have a regular doctor. About a quarter of Americans in one survey reported that they skip doctor's visits or skip taking drugs because of cost. So why is it so hard to get a doctor's appointment? Is it because there aren't enough doctors? Is it because our need for doctors is outstripping the supply? And of course, we are all part of the coming silver tsunami of baby boomers approaching old age. None of us are there yet, of course, but we're approaching it. So what are the numbers? There are about 1 million doctors in the United States, which adds up to 2.6 doctors for every 1,000 people. So once again, keep this in perspective and not lose sense of the things we should be grateful for. In most of Africa, it's 1/10 of a doctor per 1,000 people. It's one doctor for every 10,000 people. But in our peer nations, in the Organization for Economic and Cooperation and Development, the OECD, the average is 3.9 doctors for every 1,000. Ours is 2.6. Austria has 5.4. Switzerland has 4.4. Japan and Korea, numbers 2 and 3 in life expectancy, have 2.6 and 2.5. In other words, they have the same number of doctors per capita that we do. But of course, in the United States, this is also not spread evenly. Massachusetts has 4.8 doctors per 1,000 people, and Mississippi has 2 per 1,000. And then even beyond that, there are large geographic areas with no doctors at all, so-called physician deserts. And physician retirement is going to make that worse because newer doctors are less likely to enter rural areas, which is why some aging rural doctors are just hanging on because they don't want to. They don't feel they can retire. During COVID, 80% of the American population lived in counties that did not have an infectious disease doctor, and 123 million Americans live in a designated health profession shortage area for mental health care. And then we're making it worse because the Dobbs decision is driving obstetricians who are in short supply throughout much of the United States, driving them an exodus of obstetricians out of states in which abortion is now illegal. And it's driving an exodus of non-obstetricians who are reluctant to practice where the best options are not available to their patients. So in other developed nations, talking about primary care, which is certainly a need, in other developed nations, about a quarter to half of all of the doctors practicing, those ratios I was talking about, quarter to half of them are in family medicine. In the United States, it's 12%. We also have a lower percentage of psychiatrists. And part of this is that there's a broader spread of income among specialties in the United States than in other countries. And these specialties, primary care, psychiatry, pediatrics, are among the worst remunerated specialties. And you add on to that the fact that medical education costs more to the student in the United States than it does elsewhere. The average medical student graduates with well over $200,000 of debt.
Jane Hughes,
You guys must really rank because that's my daughter. And in the United States, it's the medical student who is largely responsible for those costs. We do not have large governmental offsets or governmental requirements as exist in some other countries that after medical education you have to serve in public service. For the past 45 years, the number of specialists in the United States has grown by 50%, but the absolute numbers of primary care docs has remained flat for 45 years. The U.S. has no national workforce policy and does not regulate the distribution of specialists. And so the profile within any given hospital of the specialties in which the federal money for residency program support are distributed are many systems take into account community need, but certainly a major driver there is the finances of the hospital. And we can ask Peter to comment on whether that's generally true or not. But what would be the right number of doctors? If Japan and Korea can lead the world in life expectancy with the same number of doctors we've got, is more doctors alone the solution? Almost certain. Well, I'll tell you, no, it's not, because some of the problems are larger than the number of doctors. The AAMC estimates that our current shortage is between 20 and 30,000 doctors in the United States, which is about 2% of our total doctor population. So it's unlikely that the current doctor shortage is alone the explanation for these outcomes. But AAMC also projects, and others have projected, that over the next 10 years, that shortage will be somewhere between 47,000 and 124,000 doctors. So why is our current number not enough when it is enough in other countries? Is it because we see doctors more often? Well, in the United States, patients see doctors an average of 2.6 times a year. In my case, I see doctors about 2.6 times a month, but that's I guess I'm needy. The average in developed countries is 5.7. Ours is 2.6. So in other countries, people see doctors more. In Switzerland, it's 4.3. Now get this, in Japan and Korea, same number of doctors per capita. In Japan, the average patient sees a doctor 12.4 times a year. And in Korea, 14.7. Same number of doctors. And so are we seeing doctors more than we used to? Because as I've said, the number of primary care doctors is flat. Well, the number of outpatient visits in the United States over a similar time period grew by over 50%. And of those visits, back in 1980, 66% of those visits used to be primary care. Now it's 49%. So we're going to specialists more often, and there are more specialists. The population's been growing by just under 1% per year, and the physician number has been growing by just over 1% a year. So the number of physicians is growing slightly faster than the population, but not nearly fast enough to catch up with those shortages. And then, of course, you have factors such as physicians burning out, and certainly COVID exacerbated that, so that physicians are now, a larger percentage of physicians are claiming that they intend to retire within the next several years. Talk about that in a minute. But what are the limitations to producing more physicians? So to practice as a physician in the United States, you need to graduate from a medical school. It could be a school granting an MD degree, a DO, Doctor of Osteopathy degree, or a degree from a medical school abroad. And then you need to do residency training in the United States. To be licensed in the United States, states require a bare minimum of 1 year of practice. But to be certified by a specialty board, you need to complete training in that specialty, which can be anywhere from 3 to 8 years of training. Medical students, as I've said, largely pay for the medical school themselves. And there are more than one rejected applicant for every student who gets accepted somewhere in medical school. So medical schools will not have a lack of supply of applicants and will not have a lack of supply of students willing to pay tuition. That's not the limiting factor. Residency training is, because residency training is funded now mainly by the federal government, mainly through Medicare, also through the VA, and some of medical training is funded by hospitals. So if you look at the growth in training opportunities over the last 30, 40 years, medical schools have grown much more than residencies have. And with, as a result, little change in the number of doctors. So in the 1960s and 70s, there were 40 new medical schools founded, 40 new MD schools, and 10 new DO schools. You know, 100 years ago, there were 66 medical schools in the United States. In the 1960s, before this new growth, there were 80 or 85 of them. And in the 60s and 70s, 40 new MD schools. There were 5 DO schools, and then by the end of that burst, there were 15. This growth was supported by federal funds, Hill-Burton funds and Health Professions Education Assistance Act funds, responding to a perceived need for more doctors, and particularly back then it was identified needed more primary care doctors. And then in the 1980s and 1990s, this growth stopped. There were no new medical schools founded for over 20 years because of a perceived oversupply of doctors and the feeling by healthcare economists that the more doctors you have, the more that will drive healthcare costs up. Um, and then the pendulum started swinging back. In 2001, when Florida State University founded the first new medical school in over 20 years. And in 2005, the AAMC called for a 15% increase in medical school sizes over the course of the next 5 years, which was largely met. So in the past 20 years, there have been another 30 new MD schools and 24 new DO schools. So the allopathic MD number of graduates has grown by over 30%. The number of osteopathic graduates has more than doubled. And if you're interested, we can talk about why that's been the case. So now there are 154 MD schools, 41 DO schools, producing 18,500 MD graduates and 8,000 DO graduates a year. This is not the limiting number of limiting factor for the number of doctors, because the number of residencies, if you add those together, it's the number of residencies is 39,000 entry-level residency positions every year. So it's not limited by the number of American graduates. Other things have changed among American graduates. There's been disappointingly little change in ethnic diversity, but gender diversity has changed a lot over the last several years. Over 50% of medical graduates are women. So let's talk about residency growth. In the 1960s, there was a perceived doctor shortage, and so the Medicare Act, creating Medicare, also included funding for residency training to take care of these elderly patients that they were going to now fund the care for. There were no restrictions within that act as to what specialties that training needed to be in. I don't know whether the thinking was the market would settle on the right mix, but I'll just say it, there is no free market in healthcare. So someone's going to challenge me on that, but I'll defend it. And then in 1997, the Balanced Budget Act froze the number of residency slots at the level in 1997. Most of the growth since 1997 has been in residency positions not funded by the federal government, largely funded by hospitals, and those are driven by hospital finance. So a large majority of those are in specialties that are profitable to hospitals. So surgical subspecialties, which are growing more recently, interventional procedural specialties. Back in the 60s, hospitals used that Medicare funding to support specialty training as well in oncology and cardiology, more than in primary care. So if you look at those numbers, 39,000 entry-level positions in last year's residency match, of which about 27,000 were filled by American graduates, MD and DO. The remainder were filled by foreign medical graduates, most of whom were foreign-born foreign medical graduates. But 30% of them are American-born foreign graduates, Americans who go to the Caribbean mainly or elsewhere for medical school. And that's a whole nother story, because those graduates have, in the aggregate, there are some schools that are more successful, but in the aggregate, the Caribbean schools have about a 50% match rate. So if you go to all that expense, they charge just as much as the onshore schools. And you have a 50% chance of being able to practice medicine at the end of that. You got a useless MD. There are some Caribbean schools that have a higher rate because they have special relationships with hospitals in the United States. And as I said, a whole nother topic. But so that's where we are. We don't have enough doctors. There are other countries that have as many doctors per capita as we do who do much better with it. for varieties of reasons. But what can we do to address these problems? Well, first of all, we don't have enough doctors going into primary care. We can invest in steering medical graduates towards primary care. There are federal loan programs that are designed to do that. A disappointing number of students take advantage of them, even despite the large debt that students graduate with. We at Geisinger started a program that is unique. It's been going for 5 or 6 years, but it remains unique. It's called the Abigail Geisinger Scholars Program. And the Geisinger Health System, at the cost to the health system, will pay the cost of 45 students in a class of 110. So it's about 40% of the class. Pay the cost of their tuition and a stipend, a living stipend. For all 4 years, if the students would agree to train in a primary care field and then practice in Geisinger in a primary care field or psychiatry for 4 years, after which they can go and become, interventional cardiologists or whatever. But they,
Steve, to interrupt for just one quick second, fewer doctors going into primary care. Is it primarily because of the financial rewards or less because it pays less, or they just don't want to take care of whatever? Why the move away from primary care?
That's a really important question, and many people focus on the compensation because you could certainly make much more as a surgical specialist or as an interventionalist or as a cardiologist or whatever. But
what sort of orders of magnitude?
Double or more. I mean, the average compensation for a primary care doc is about $250,000. So that's more than doctors make in some other countries, and it's not a bad income. But you can make almost twice that in many medical specialties. You can make more than twice that in surgical specialties, and there are some specialties where you can make close to 7 figures. And also opportunities for non-practice related income exist for anybody who's got enough money to invest in things. But for example, I'm a nephrologist, and it scandalizes me to know that it is perfectly legal for a nephrologist, and many of them do have more of their income from investing in dialysis units than having more income from their investment in a dialysis unit than what they make from seeing patients. Clear conflict of interest when the best interest of the patient might be a transplant rather than dialysis. So there are other things that contribute to physician income, but there are other reasons other than income. In medical school, when I went to medical school, which granted was in another century, the people who were really respected the most were the NIH-funded researchers and the high-end specialists. Primary care was not something that you were raised to think of as that challenging. When in fact, I think it's more challenging than a specialty because you have to know everything about everything. So I think this is one of the reasons why a higher percentage of osteopathic students go into primary care, is that the culture in osteopathy respects primary care more. Now, having said that, there are MD granting schools where that culture is also shows more respect, and they're role models. But I think it's a combination of factors. So let's make a few other comments and then open it up for everyone else. So there are ways to steer people towards primary care. Everybody knows that NYU and now other medical schools have waived tuition for everybody. That's something that I have said. I've criticized in print. Among friends, I'll call it promiscuous generosity. Because a kid who comes to medical school from Beverly Hills, wealthy parents, and then wants to go back to Beverly Hills and practice plastic surgery does not need to go to medical school for free. NYU is not doing that because they think it will help help outcomes. In fact, since they did that, the racial diversity at NYU has gone down. The number of graduates of NYU going into primary care specialties is lower than the national average. NYU is doing it so that they can compete for the most competitive, the most attractive students, compete with Harvard, and move up the US News rankings, which is a pernicious phenomenon. US News is only a ranking publication. It's not a news publication anymore. And it's don't get me started on that one either. Other things that could be done. The federal government could expand the J-1 visa program waivers and use other strategies that would make it easier for foreign medical graduates to come in and practice in the United States. Many people disdain seeing a doctor with a foreign accent. But they are the barriers to their getting here and finding a residency are often very high, and it's in many cases the very top of those medical school classes who end up here. We could do more to address or this is happening already. Address drivers of physician burnout, burdensome documentation, the culture in healthcare organizations. These are being addressed in many places because physician burnout is causing us to lose valuable physicians earlier or to make them less productive. After COVID, 20% of doctors said they plan to leave practice in the next 2 years, and fully a third of doctors plan to reduce their hours. We could hope for an expansion of federal support for residency positions in primary care. There have been some small targeted increases in primary care, although they largely have ended up supporting urban programs. And there's a new proposal in Congress the last couple of years for 2,000 additional positions in primary care. That's been stalled in Congress, as most of Congress's business is stalled. But we could also reduce our dependence on physicians for care. We could expand the numbers and roles of non-physician caregivers. Physician assistants, nurse practitioners, RNs. We could do more to expand their scope of practice or to help arrange that they are practicing at the top of their scope of practice so the doctors could be practicing at the top of their scope of practice. Telehealth is something that if it's used more widely, and it is growing, can increase access in underserved areas. And AI can not only be a valuable tool, I'm not saying it isn't going to wipe out the human race because it might well do that, but it could be a valuable tool to physicians to help ease their work as they try to care for more patients. And it can also, over time, help address the burdens of billing and documentation of the things that lead to burnout. And then we come to larger societal solutions. And so these are the easy ones, right? Like addressing the social determinants of health, food deserts, economic inequalities. And those economic inequalities have been growing. The difference between those making the least and those making the most has been nothing but growing since the 1980s. We can improve preventive care, improve access to prenatal care, improve coordination of care, expand clinic access to reduce burden on emergency departments where the care is often not coordinated, strengthen our fragmented public health infrastructure, and COVID certainly demonstrated our weaknesses there. Phase out fee-for-service payments in favor of value-based care so that people are compensated based on outcomes rather than how many procedures they do. This is an old argument, but incentives drive behavior. It's just simple human nature. Compensation reform to reduce the gap between primary care and the highest earners, and to create a national healthcare workforce program that would develop strategic policies that would help steer those Medicaid dollars in the direction that best serves the national need. So those are easy, right? It's simply a question of national will, and unifying the national will is easy these days. So I'll stop there because
I was going to say, Steve, we all know how unified the national will is currently.
Right. So I'll invite the docs and the healthcare administrators on this call to take issue with anything I've said or to expand on anything or offer your perspective on why it's hard to find a doc?
Don't the doctors, now, come on, you guys, step up and.
I'm
Well,
happy to chip in. Hi, Steve. I'll
Here,
I'll stand in as the hospital administrator side of this thing, and somebody who is really a lot involved in policy at MedPAC and other places. So I have one kind of question for you, and then one comment. You mentioned physician assistants and nurse practitioners briefly, but there are like over 500,000 of them, and they're really ramping up enrollment and with a lot shorter educational time frame at a lot less expense than doctors. So I see it as, I'm asking, that is maybe a more realistic way to fill some of the gaps. So that's a question. And then while I'm on my comment is that I can't help but mention Medicaid, both because it impacts is the lowest paying payer for doctors, but 1 out of every 4 Americans is in Medicaid now, and it surprises people that 75% of those people actually have jobs. They're not just sitting on the sidelines poor, and yet that is by far the biggest target of all the federal spending cuts. It's just about to get unveiled. So you could comment on the nurse practitioner side and that, but we're going to have a lot bigger problems than the shortage of doctors, I think, in terms of access when the hammer comes down on Medicaid in the next several months legislatively. So your thoughts on that?
well, first of all, I share your concern about Medicaid, and I'm scared about that as well as many other things about shoes about to fall or axes about to fall. But to your question about PAs and nurse practitioners, I think that there is the real opportunity for them to help address some of the worst gaps, such as in the physician deserts, the large rural areas where physicians just don't want to move. And most of the resistance to expanding their scope of practice comes from, ironically, from physicians and largely from, or much of it from primary care physicians who might feel that they could be supplanted by PAs and nurse practitioners, which from a market point of view flabbergasts me because we've been describing for the last half hour how difficult it is to get an appointment with a primary care doc. They do not have problems filling their rosters. And many of them are not practicing at the top of their scope of practice because they're burdened with tasks that you don't need 4 years of medical school and 3 or 4 years of residency to do. The surgeons are very good at this. The surgeons and cardiologists and other proceduralists have made great use of PAs and nurse practitioners to make their offices more efficient and have them have the extenders take care of those tasks in the office that you don't need an MD to do, so that they can be out there, ringing their cash registers for the things that are most remunerative for their time. So we can look to other countries. People talk for years about the barefoot doctors in Cuba, who, with less training than a PA or nurse practitioner, were at least addressing the minimal, the basic public health requirements of a population. And I wouldn't propose that. But there certainly are. I think that that physician extenders. I welcome the growth in those specialties, and I think that they can fill some of the more needed gaps, not only in primary care but in mental health care as well. But I'd like to hear the perspective of some of the other guys in the audience on that.
Steve, this is John Black. Thank you for that truly awesome summary. And I think you covered virtually every base and identifying the problem and identifying some potential solutions, some easy, some hard. Love to appoint you. I'm sorry that Trump is not appointing you to head CMS, but you would probably have about as much effect as Don Berwick would have had if he'd survived.
Right.
Anyway, two other things that I think add to the problem. One is all the money we spend on end-of-life care. Our society has always been extremely reluctant to deal with that. Our culture is 20 burly men die trying to rescue the child that's fallen in the well. And specialty orientation has fostered that as well. And the other is uh, the youngest generation of physicians is not likely to work 80 hours a week like probably all of us did. As a residency director for 15 years, I wouldn't put current students through what you and I went through because it was inhumane. On the other hand, we need more doctors because they're not going to be on call every other night. They're not going to work 80 hours a week, nor in fact should they.
I agree with both those comments. As far as those hours, though, you're right. But I don't think that people need to work 80 or 90 hours a week to achieve what is achieved all across Europe, for
Totally.
example.
And another factor that affects us here is that healthcare is run as a business rather than a public good or a public service. And I think that shapes everything because the bottom line is the bottom line. And that's a big cause of the physician burnout. I don't think increasing the number of doctors will necessarily address the problem because they'll continue to get burned out because the feedback I hear from my colleagues who are still working is that it feels like they're working in a widget factory and they just have to crank things out. So the humane values that drew people to medicine are not prioritized anymore. Plus the way medicine is focused is so much on finding a medication and not dealing with underlying causes like lifestyle issues that we've touched on, things like obesity, exercise, stress management, what have you. So it just seems like we need to have a massive reorganization, and I don't know where the political.
You're breaking up a little bit, Rick.
Philip for dinner at Longhorn, but it's good because I don't think Grandma just been out of her apartment for over a month, so she's willing to go out. So that's
I'm not sure who's talking.
Whoever's talking is
I
not
don't think it's a
audible.
classmate.
Mark, I say this, I was trying to figure out a way that
Somebody's
she
got
could
a
listen to
radio
books
on, I
tape,
think.
CDs on tape, books.
Can
on
can
CD.
you
CD
mute them as a
don't.
host?
That are just a really old style.
I can.
There you go.
Nothing fancy, no
No.
headphones, no, yeah. And
Does
she
one
tried
of
that
you know
with the Barack
which
Obama
one of you should be
on
muted?
CD.
I
So
don't
figured
I don't
out
hear
that
it.
Well, she could hear it pretty well, and then I cut out a little piece of paper. And
Why don't you mute everyone and raise hands?
Yeah. There you go.
Yeah. So, well, Rick, you're right. Medicine, that hospitals and practices are run like businesses. That's partly because they need to pay their bills. I mean, the people decry the rise of for-profit hospitals, and I worry there in particular. But we forget that the self-employed physician is also a for-profit model. Now, the majority of medical graduates for the last several years have been going into employment by systems rather than private practice.
Right.
And I personally think that's a good thing because I think in the long run, systems are in a better position to coordinate care than individual private practices struggling to get records across to the next practice, and communication is just not what it can be in a system. I'm not saying that all systems do this successfully, but in those systems that do, the care is better at a lower cost.
Well, I'd still like to see some more movement towards Medicare for all or something along those lines to cut out that whole administrative layer to it.
Well, it's probably okay at that segue to give you the answer. I foreshadowed this by telling you Bernie Sanders represents much of this idea. I hope I'm heard. Am I heard?
Yes.
Okay. So I'm just going to give you 3 points. The first is I think healthcare needs to be a right. It isn't. It's argued across the political spectrum. It has to be considered a right. Number 2, I think the only solution will be the single payer Medicare for all. That is Bernie Sanders' words. I'm hoping, and you see this in the political spectrum, that the Democrats will come forward with this as a straightforward platform to be voted on. I think it's the only way that it will ever come to fruition. I'm not sure it will, but to test the will of the people and all the things that were said, that I'm hoping is where it goes. It does get to the second big thing that Bernie talks about, which is the discrepancies in wealth. So I think that's the broad picture. I'm hoping in a few years we can turn that. The second thing is it is money. There's no question it's money. There's a huge pile. You could say 17% of the GNP. It is incredible how that drives. And I'll just give you one example. In the UVM ER, when we started, as Steve said, in the prior century, we had no doctors. We had 2 residents and 2 interns running the ER. When the hospitals can get money, they develop the ER. Now there's 32 doctors and it's a specialty. And just as a parameter, care in the ER is on a normalized scale is $1,700. Care and urgent care for the similar problems are $175. And the same care in primary care is $85. So there's no question people go to the money. The last, I'll refer you to T.R. Reid, The Healing of America. It's an old book, but it's outstanding. And I'll tell you, he's an esteemed colleague of our colleague, Dave Brown. I'm sure he sat next to him. You can read that Japan, apropos to what Steve said, all meds are set at a set price for the nation. Wherever you go, that's what you pay. Number 2, doctor visits are 10 minutes in Japan. That's why they see 12.4 per year are seen, because it's 10 minutes. It relates to regulations that are fostered primarily by Medicare and all the time spent with regulations, et cetera. So there's a lot of movement there. The other 2 things are Canada, which everyone knows, adopted our Medicare idea in the 60s in a province, and politically it worked remarkably, and the whole country. The last one is Germany. To give you an idea, they have private in addition to public. So you can have a 2-tiered system for, quote, the wealthy. I do think if you read that book, you would see that this can be done, Medicare for all or single payer. And the goal should be better health care for all of us. So that's the solution. Let's hope it happens. That's
So,
it.
Dick, thank you for that, because I agree with everything you said. Now, there are various versions of Medicare for all, and when the sausage was being made, the Affordable Care Act, it included the equivalent of a government option was what it was called, and that was very close to happening until Joe Lieberman caved to his constituents in Hartford, all those insurance companies, and was the key vote that prevented that from happening. But even if there is a government option that within the options for the Affordable Care Act, the panoply of multiple insurance companies with the ability, even if the government doesn't have that ability, the others do have the ability to deny service, et cetera, would still be a huge administrative burden. So I remember when this question was asked to the Democratic primary candidates in 2016, would you shut down private health insurance in favor of Medicare exclusively? Amy Klobuchar wasn't sure which hand was going up, but it's a very difficult question because that is something that Americans, I think, would be reluctant to let go of. And then, of course, your hope that disparities will go away. In the last 2 weeks, we have every reason to think that more money will be sucked out of the poor and sucked upwards, services for the poor, et cetera, to fund tax cuts. So I love hearing from you, Dick, because you live in hope against all the evidence.
Thanks,
Can I ask,
Steve.
can I ask a couple questions? First, is there anybody here, and I mean this in a straightforward, non-cynical way, who thinks that there's any prospect of what Dick described coming to pass in the next 20 years? And just let me get the second question out because it's unrelated. And maybe this is something that tend to see here in New York and not as much around the country. And that is, and I think, Steve, you touched on this, doctors, very good doctors, very successful doctors with a lot of patient demand, leaving the profession because they can make a hell of a lot more money doing something else, like being a medical advisor for some venture capital fund or being being entrepreneurs themselves. I don't know if the numbers to that are big, but when it's happened, and I've seen it happen, it's discouraging. Not to them.
Yeah, we've all seen that happen, but I don't think the numbers are big enough to affect what we've been discussing. But I do think that when a doctor says, I'm fed up with this, they're all going to have other options of things of things they can do. I think Dave Gordon's had his hand up for a while, very patient.
Yes. A couple of things. One, I think obviously this is a multi-pronged problem, and probably no one thing is going to be able to really drive this. But I think some other things that need to be considered, and I'll just make 2 or 3 comments here. One is that, we really have not had much emphasis, in my opinion, on making healthcare cheaper. You look at many other industries, not all of them, but many other industries. I take, for example, the computer industry, and I realize this is apples and oranges. But if I buy a laptop today, it doesn't cost that much more than it did, 5 years ago. And yet the capability has gone way up for the average laptop. I don't think we have really thought hard enough to really say, how can we make healthcare cheaper? And just to give you a small thing, for example, I'm a cardiovascular pathologist, so I'm a subspecialist in a field like pathology. And frankly, a lot of my colleagues, will have a case and will say, okay, look at the slides and then let's order a whole bunch of special stains, as opposed to kind of using our critical thinking and really asking in hard care, are these stains needed? Because each one has a bill associated with it. And so in my older age, as I'm getting more arrogant, maybe hopefully experienced, I'm not ordering as many stains because I can see the context and I say, gee, this is not something that we absolutely need. And at the same time, each of these tests costs a bill, that someone is going to have to pay, either the patient or whatever is going to pay. And so I think more of an attention to those things need to be, focused on. The other thing I'll mention is that having been a dean of at least 2 allied health schools, if you will, and that's an oddball because you usually don't have MDs in that role, I really think that we have ways to go to really foster interprofessional teamwork in terms of the healthcare. I mean, we talk about physician assistants. We even have pathology assistants, for example, that work in pathology, that analogous to the physician assistant. But when you talk about nursing, you talk about other fields like physical therapy. I mean, you'd be surprised. I had to learn, by being a dean like that, what physical therapists can offer. And I don't think we leverage enough of what physical therapists, for example, can do, let alone pharmacologists, let alone other areas. But I think at the university level, we do have an opportunity to really work with getting the kind of teamwork that can make things more efficient, including bringing on AI in a reasonable fashion, with some attention to its concerns. And then I guess the final thing that I would say is that it seems to me university systems, of which have a lot, and we're often the referral centers, for example, for difficult cases and things like that. We can be places that can model, cross subsidies of different things. So, I mean, I think it's a bit ironic that we can tend to pay the primary care person, less than we do the cardiac surgeon. But in fact, the cardiac surgeon, by and large, would not be getting much of their volume if you didn't have a primary care person referring to them. And so this notion that somehow the primary care person is less valuable, even from a business point of view, than the surgeon, I think is, a little bit taken to extreme. I'm not saying that, you even the playing field and just have everybody earning the same thing, although I've occasionally heard that Mayo Clinic has something along those lines, and they've been a pretty successful, healthcare system. But it seems to me we as an institution can do more in terms of cross subsidy, and particularly be able to reward the primary care folks for the work that they do. It may come at the expense of someone who says, gee, I want to be a private, dermatologist or dermatopathologist, for example, and I can go out and make more money in private practice. Well, in my opinion, we have to really ask the hard question, does that person belong in academia? And are there other people who can take that case, that take that place? So I don't know. Those are just some thoughts that I think we need to consider as well.
David, thank you for those. And I have a lot I could say about the comments you made, but I'm going to pass because there are several people with their hands up. Other than to say,
can I interrupt for 30 seconds?
Yeah.
Steve, you're now the host of the session.
Oh,
I have
boy.
to unfortunately leave. Not you, Steve. Mr. Clemens down here. I just have to disappear.
Okay.
And Steve, thank you. And thank you all
Go
for
ahead.
coming. And have a good time, guys. Sorry I have to go away. It's my 97-year-old mother-in-law, and you know how mother-in-laws are.
Thank you, Bob.
Bye-bye.
So the only comment I'll make before handing it over is that systems have been recognizing the importance of primary care feeding into their remunerative specialties, and so the systems have been very eager to acquire primary care practices for exactly that reason, as the entry level into the things they make more money on. So somebody else had their hand up but has disappeared. So David?
Yeah, I don't know what happened to John Hayden, but anyway, Steve, you mentioned that in primary care, you have to know everything, and that's it's ironic that they're not at the top of the income heap. I think the fact that you have to know everything is one of the things that causes people to burn out, especially if you have to know everything in 20 minutes and as well as review all sorts of the patient's behaviors and preventive preventive interventions and describe all the potential adverse effects of what you're prescribing, et cetera, et cetera. But there is something that does know everything, and it's AI. It's not that it doesn't make mistakes, but it does know pretty much everything. And if it's supervised pretty well, from what I've read, it can be highly useful. So my question is there any system, health care system or academic institution that is really trying to be the tip of the spear of bringing this into practice? Or are we just going to have to wait for like the 30-year evolution in which everyone eventually got an electronic medical record, but it was 30 years after the first health systems did? because, you know, my own personal view is that AI and nurse practitioners or advanced practice nurses or PAs, you know, supervising and doing all of the human interaction and explanation at a with more time and at less cost than an MD. You know, that there's a lot of, may not be low hanging fruit, but you know, it's sort of step ladder fruit. But anyway, is anyone? My main question is, do you know of any systems that are really trying to use AI in an ongoing way, you know, sort of routine?
Yeah, I don't know that there's one system that's leading the way. There may be, but I'm not aware of it. But I think that multiple systems, especially the more sophisticated ones, the ones with the resources to have an innovation or an AI department, are doing this, and I think we've seen it for years, relatively imperceptibly, where, for example, systems that have electronic ordering on their electronic medical record, that EMR will tell you the cost of what you're ordering. It's AI that's doing that, and that's a relatively straightforward development. But Geisinger, for example, has an innovation, a whole innovation team. It's fairly large, that is working on just these sorts of things to bring AI into the practice setting. And I'm quite sure that there are other large systems that have these resources that are doing it as well. So I think we will see it over time, and that other systems will adapt the best practices that or more likely, the systems that develop it first will commercialize it and make it available to other systems.
John, you've had your hand up for a while.
Yeah, can I make a couple of comments? Nice to see everybody here for this meeting. I was a primary care doctor for 35 years, and I worked down the hall from Dick Tonino. So I'm going to go a little bit out on the limb and say that I agree with Dick that some sort of Medicare for all system will come within 20 years. But I think it's going to be a two-tier system, maybe similar to what Germany has had, where there'll be a basic system that's available to almost everybody. And there'll be a buyout system for people who can afford to pay more. I think that'll be a lot more palatable in our country. That's just my guess, but I haven't studied the German system in great detail since I was a fellow, so it's been a while. The other thing I would say is my daughter, who's a primary care doctor with Kaiser, has been there for 10 years now on the West Coast, uses AI to generate her office notes and is pretty happy with it. So in response to Dave Brown's comments, I think that's coming. And of course, it's just going to improve a lot in the next few years and will take some of the burden off of some of the administrative work that many doctors have to do. I'm sure there are applications, not just in primary care, but elsewhere. So thanks.
David,
You want
Yeah, so just one quick comment about AI. I mean, I do want to see AI be used in medicine, but I guess I have one caution, and that is, you know, there are all kinds of different AI systems. I think what we need, again, maybe this is something that a university health system can promote, is really what I call a sanctioned AI in terms of, you know, what people really buy into and some sort of fact finding. I mean, I've heard that there are AI systems that when you start looking, either they can't tell you how they came to their decision, which I think is a real big no-no for an AI system. I don't want to accept an AI system that can't tell me how it came to its conclusion. And B, you know, an AI system that don't provide you with either the references or the basis on which they made their decision so that you can double check. I've heard that in some cases when you run, say, ChatGPT, and I don't know, I haven't had much experience with this, but I've heard that some AI systems will make up references or will, you know, seek other references that we wouldn't really consider. And so that's the only caveat that I have about, you know, the use of AI. I think it needs to be used, but it needs to be monitored and it needs to be kind of, you know, overseen.
Let me see if somebody wants to bite off a slightly different piece of this. Putting the prospect of a single payer or Medicare for all aside for a minute, assume we have a system that is the same or resembles what we've got now. Things getting or going to get better, worse, kind of stay the same?
Worse before they get better.
Yeah, and more expensive. Unfortunately, I think, there's some wonderful new treatments for cancer and autoimmune diseases and things. And I think the costs are going to continue to go up. And that will be, I think it's ultimately
You're
going to
talking
be
about cost of new therapies as opposed
yes,
to
which are
demographic.
wonderful, wonderful therapies,
Yeah.
but very expensive. And,
Healthcare used to not cost so much because didn't have as many
penicillin-
pieces and as much cost associated. It just couldn't do it.
penicillin was cheap.
A very quick comment. There is a huge movement to remove diet, exercise, et cetera, for obesity and just use drugs. There's, there's just to tell you how things can develop and technology can help. That's a huge thing to say, all that we've done for 20, 40, 50 years, it's now just a drug for our quote of obesity.
Is that a good
And
thing?
there's a huge movement on that.
And that's a good thing?
I'm not commenting on it's a good thing or bad thing, but it is a major thing to use drugs and not again, you use diet and exercise, but that hasn't worked.
Yeah.
Right? We have done that for 50 years and we have 75% of people based on definition obese. So I'm just saying that you can see this in reasonable press like The Atlantic and other places, people talking about it. Don't bother to do diet and exercise. Just use the drugs. They're so remarkable. Just a comment in terms of where things are going. Where that'll go for economics is to be determined, but that may be a huge movement. I'm not fostering that. I'm just saying that that's really there. Quite remarkable, right? To change in 5 years.
Certainly drive up cost.
Well, Steve, my comment on better or worse, short-term worse, I'd agree. We went from about 50 million uninsured down to as little as 20 million uninsured with Obamacare and Medicaid expansion, and we're about to go in reverse for a while. But I do hold out optimism, not for Medicare for all, but that everybody at least will have an insurance card someday. What the system looks like under the card is still going to be pluralistic, but I hold out optimism that we'll have everybody have some kind of card in 20 years.
Yeah, part of my question was, the Affordable Care Act did improve a lot of things. Has that kind of been maximized and is that at those improvements at its limit, or is there some more to be squeezed out of it? It's kind of a race between some of the additional expenses and outcome issues, and whether there are ways for insurance at least to ameliorate some people's problems with them.
Well, to Peter's,
like a 26
Affordable Care Act has accomplished a lot in terms of the number of people uninsured dropping significantly. But I think whether that number will improve further is entirely a question of how the Affordable Care Act is respected and managed. But the Affordable Care Act itself was just an insurance act, just a coverage act. It did not address most of the fundamental social determinants that I was talking about. And if what we want to do is improve quality and reduce cost, that's where we need to go.
Well, Dick, do you have or have promoted, or as Bernie Sanders promoted, ways to make people healthier other than by having Bobby Kennedy as the head of HEW and setting a great example and stuff. Seriously, I mean, you say, and it's quite sure it's true, the lifestyle problems have persisted and haven't gotten better. I don't know how much worse they've gotten, but what kinds of things could have been done or could be done?
Well, I think one huge driver here is tax policy. The policies that have been pursued since Reagan that have promoted this huge income inequality. And if that's not addressed, I think much of these problems will remain. John's had his hand up patiently.
Sorry.
Thanks. I spent the last 9 years of my career arguing with insurance companies to remember their obligations, and became very impressed with the data analytics creativity of Medicare Advantage plans. In terms if you may have seen over the last year, the Wall Street Journal has done a series of articles of how they make money, and they're really very clever at it. If their motivation were not profit for their shareholders, but improving cost and quality, that would go a long way to solving our problems. And perhaps we could have some sort of quasi, Freddie Mac, Sally Mae organization that was quasi-governmental and subject to regulation and standardization, but not necessarily be totally government alone.
Okay, we're a little over time. If anybody has a final comment, Steve, you want to conclude? You're not obligated, but if you have a thought or two you want to share, or anybody else. But
Well, I think it's
wrap it up in a few minutes.
I think this has been a great discussion. I appreciate everybody's insights here. I've always thought it was ironic that while we do have a number of doctors in Congress, in general, they tend to be on the Neanderthal side. And because they're all cardiac surgeons who feel that they earned their place in society, and everybody else damn well should do the same thing. But it's one of the reasons why I'm less optimistic than Dick Tonino, but I was also born less optimistic than Dick Tonino. So I've really enjoyed this discussion, and look forward to whatever the topic will be next time.
So this is Blaine Rodden speaking. I'm a too frequent patient and not a doctor. And I thank you all for taking care of me indirectly one way or another. And I appreciate it. And I believe I am speaking next month on the topic of human-powered airplanes and solar-powered airplanes. So it will be a considerably, oh, no pun intended, considerably lighter topic. I look forward to speaking with you, and I really found this super interesting, and thanks a lot.
Yeah, well, Blaine, if you can make the time fly as quickly as it did for this session, it'll be successful.
Okay.
Yeah, you'll hear more about that. Let me just remind you, we're trying to do these once a month, and if there's something you'd like to talk about, or there's a classmate that you think you'd like to hear talk about something, you can please let any of us know. Our email addresses are on the emails we sent out, and look forward to seeing a lot of you next month with Blaine and in the months thereafter. But thanks very much to Steve and to everybody else. It was a lot of fun, and I learned a lot.
Thanks, Steve.
I remember some of the things I learned. So long, everybody.
So long.
Thank you, Steve.
Thank you.
Okay. Oh, this is so.
Yeah, I'll wait till everybody's off before I end it. Hey, Blaine.
Yes, I can't find the get off the meeting button, but
So
okay.
I'm going to end it for everybody now that we're
Oh,
down to
okay.
this. But
All
I
right.
have one question I wanted to ask you.
Sure.
But I'll send you an email in a minute. But a couple of weeks ago, my wife called me and she was watching a PBS documentary about some aviation pioneer, some sort of nutty guy, and they happened to mention that he was an Amherst graduate. I'll send you the thing.
Was it me?
No. This is 100 years ago.
Oh, wow.
Almost literally 100 years ago. Early
Wow,
guy. He was, the prize that Lindbergh, I think he won it, that he was competing for the first transatlantic flight.
Yes.
This guy was trying to win that, and obviously didn't succeed.
Oh, really? Uh-huh.
I'll send you. There's a kind of an ad for the documentary. I'll send it to you.
Yeah, I'd like to see that. That would be very interesting.
Yeah.
And
Well, you'll see it in a minute.
there's an Amherst guy who is an airline pilot who's written a couple books.
No, I don't know about
that. Can you wait 30 seconds? I'll run into the bedroom and see if I can find the book.
Well, I'll keep the line open, and meanwhile, I'll get this guy. We'll both do a little research.
Okay.
I'll be back in about 20 seconds, I hope.
Okay, good. Okay, I found one of the books. I might have loaned the other two to my niece. The guy is younger than we are because he's an airline pilot. And what's cool about the books is he doesn't talk about how to fly an airplane. He talks about, he uses the piloting and the business where he's flying long range flights. So he might be in England in the morning and Africa in the afternoon, and all the adventures he's had with people and the different cultures and whatnot. And it's the two books that I read were beautifully written, like river stones, really polished. And
What's
the guy's
his name?
name is Mark Van Hernicker, VanHoenaCke.
No, I was confident I'd never heard of him, but I haven't. And I have not found this guy's name yet, but I will in the next.
Okay, well, you email it to me.
I'll send it to you in just a minute.
Yeah.
Okay.
So the book he wrote was called Skyfaring, Faring, Skyfaring. Anyway, if you're looking for a travel log book written from a quite different perspective.
But he's talking about kind of his life or his theory of how you fly an airplane, or
no, it's not about it's about what flying enables and how and it's basically life stories, but but it's the clothesline on which they're hung is flying a 747, and having that clothesline take you from one story to another, sometimes very abruptly, where you've been out and back into a completely different world, and now you're back at home, and it seems almost impossible that you were in a completely different place.
I was telling somebody this recently, and it's something I hadn't thought of for a long time. My father in World War II was an air traffic control instructor. So as he took different tests, he just enlisted, and he took a test to be a radio operator.
He was smart enough to actually go and do the thing for which he was qualified.
But he didn't know that. But the big, I remember him telling the story, the big difference was air traffic controllers were being sent, and I think he said Europe, what he was doing Europe rather than the Pacific. I guess in the Pacific they did them in the Navy rather than in
you're mostly
Air
an
Force
aircraft carrier.
From aircraft carriers, but they wouldn't put somebody from the Army Air Force on there. But if you become an instructor, you basically travel around the U.S. teaching people to go do that, which must have had a much higher life expectancy.
Yes. Yeah. My father had an opportunity to be a weatherman and a couple other things, which he turned down because he was already loyal to his unit. Ended up in the foot soldier, sniper in the Battle of the Bulge, got captured, spent time as a POW. Not the best set of, just too gung-ho. And anyway, he survived, but that was lucky.
I know there was a guy, a good friend of mine a year behind us, named Mark Hinckley, whose father was father went to Amherst, and he was one semester short of graduating when he, Pearl Harbor, when he enlisted. Never finished, but he was in a POW camp, and they never ate potatoes.
Why is that?
Because that's all he ate.
Oh, I see. He won't have potatoes now.
Right. Well, I mean, he's dead, but growing up, this guy, his father was home, which he generally was. They never had potatoes. He wouldn't eat them anyway.
Yeah.
But he also didn't like having them around.
Yeah. Yeah.
Okay, let me find this guy, and we'll be talking over the next month.
Okay, yes. Now,
Yeah.
I am going to be on vacation. If you can be on
You're
vacation.
coming back a couple of days before this, as I recall.
Yes, that's right.
Yeah. But what if you said when you're leaving, I don't remember. So
I'm leaving on the 15th, and I'm coming back on the 1st of March.
Okay, we should just be in touch. Oh, on the 1st, I don't have a calendar. What day's the 1st?
The
Tuesday?
the standby, 1st of March is Saturday.
Okay, so
and we're
we're
talking on Thursday, so
right. We would be doing this on the 5th or whatever. I just pulled up my calendar.
Yeah, so it's going to be on the 6th. On the 6th.
Yeah, the 6th is the 6th is Thursday. Okay, so we'll talk during that week, but I'll talk to Bob, but you should check in with him or somebody before you go. Just make
Okay,
sure
good.
that obviously if anything changes, we'll let you know, but maybe just make sure. Where are you going? Someplace interesting.
I have to go sailing in the Caribbean with a friend on a 48-foot catamaran.
Very nice.
Yeah, I've done it one time before, and it was the softest, most benign place I've ever been. It made Hawaii seem kind of harsh and crisp. So I don't know if you've been to Hawaii, but it's pretty lush, and this is even cushier. So
yeah. Okay. Well, have a good time, and we'll be talking.
Okay, great. Thanks a lot.
Thanks,
Okay.
I was debating when you stepped in whether to do a promo for you.
Well,
but
I wanted to say thank you because I have received better than average healthcare, and I would be dead otherwise. So okay,
I think I have too, but sometimes it's a struggle.
Yeah, well, yeah, it's a struggle, but it beats the alternative. So
exactly. Okay.
Okay. Real
Thanks,
good.
Blaine.
Okay. Bye-bye for now.
Take care. Mary? Do you remember the name of that guy?
The short name was like Post.
Post? Oh, I think it was Post.
Yeah.
Because I remember saying something about was related to Meriwether Post. I said that.
Yes.
Yeah, I think that's right. Well, that's all right. Yeah.